Arrived. We are very pleased to have this workshop this afternoon. We have an exciting program underway, and I'm going to ask Margaret Soden, our facilitator, to take over.
Great, thanks, Margaret. Come on in, we're starting on time because Dr. Coates is actually going to stay as long as he can, but he's got a plane to catch, so we want to stay on time. First of all, just welcome. Thank you for being here. There's people here from coast to coast. It's absolutely fantastic. I'm delighted to be here. I'm delighted to be a facilitator for really two reasons. First of all, I'm from Montreal, so it's pretty cool after a lifetime to come back to Montreal and be part of something like this. It really is. But the second and far more important reason is, if you look at the title of this session, Addressing Unmet Needs, we're here because of the patients in this room. We're here for the patients of the caregivers who are in this room. And we've really got to deal with the unmet needs. So there's a lot of genuine interest. I'm really excited about our guest speaker today, and I'm excited about the things you're going to be doing. I always like to know the customers in the room. You're the customers. You're the customers for Dr. Coates. You're the customers for 5E, and you're the customers for this session. How many of you in the room right now are actual patients? Just a show of hands. 1, 2, 3, 4, 5. How many are patient caregivers? 1, 2, 3, 4, 5, 6, 7. So about 50-50, Dr. Coates, that gives you a little perspective, and more will come in. In terms of administration for any session, if there was an emergency, you've got the 2 exits. I feel like a stewardess. The washrooms, if you go back down to the registration desk, just to the right-hand side if you were facing the registration desk. If you hear me use those little chimes I used earlier, that means I really need your attention, and I found years ago that was a lot better than the whistle or screaming, so that's my polite way of saying, please. And you will find out in a minute there's a little change about coffee, but we do have water in the room up there, so just, help yourself to water. All right, why are we here? Sorry, I'm definitely on to, yes, right, okay. Why are we here? 4 reasons. We have the privilege of having Dr. Coates here, and he'll be introduced in a moment. And he's going to update us on the status of the task force, the interim report on environmental health. And that will lead to the second phase of his work, so this is awesome. This is like momentous in its opportunity. The second thing is to provide input to Dr. Coates' task force. Now, there are people here from other parts of the country, but we have had people submit input to him already, and he's going to be walking away, as is Faideen from the ministry, with phenomenal input coast to coast. And we think that input's going to inform his task force. We think it's going to inform policy. So thank you, but also Dr. Coates is going to look forward to input from you verbally today. The third thing is we're going to provide some education. Very important. If we are on the same page of the language at a meeting, then everything flows from that. And when was the last time, Margaret, that people were together coast to coast like this? Patients, caregivers, like never, maybe? So take this opportunity, talk to each other, pollinate the ideas, and this will be not only an awesome afternoon, but for those of us staying on for the next couple of days, really an opportunity to cross-pollinate. That's what we want to achieve. Form follows function, so the agenda follows that. And the only thing I'd like to mention is the break at 2:30 is not going to happen at that time. I'll let you know when it's happening, but we've been put into the break that goes with the larger conference. So that's going to happen around 3 o'clock, 3:15. All righty? So without further ado, I'd like to invite Larry Daw to introduce Dr. Coates.
Bonjour. Mon devoir pour cet après-midi consiste d'introduire le personnage distingué qui nous parlera au sujet du Task Force Environmental Health Interim Report being done in Ontario. Dr. Ray Coates is the chair of this task force. He is intimately connected with the Ministry of Health in Ontario, with University of British Columbia, with teaching, research, and practice in environmental health. He has an MD and MSc from McGill University, and he's completed training in family medicine at Victoria Hospital in London, Ontario. I'd like to introduce Dr. Ray Copes.
Thanks, Larry. Can you hear okay back? Perfect, thank you. Well, I really appreciate the invitation to speak with you today and to get input from you on your thoughts. And certainly, you know, the meeting here and the National MEFM Action Network and the great work you do. So thank you very much for this opportunity. I guess I should see now if we can get the slides up. Yeah, that's perfect. And you know, just for convenience, it turns out that I wore exactly the same suit and shirt like when I got that picture taken. Pure coincidence, I assure you. And I guess before I start, I should sort of apologize that I actually came into the task force very late. Okay, the initial task force chair was Dr. Howard Hu, Dean of Public Health at University of Toronto. Dr. Hu is doing sabbatical in Seattle this year and was unable to continue chairing the task force. So he early on suggested that I would take over for him, and I was a little unconvinced that I was the right person. However, there were a number of other people who came to me as well and said, would I please do this? And it is a fantastic opportunity. So I am now the chair, but please, I did come in fairly late. The interim report was just being developed and released at the time I took on the chairmanship of the task force. So I should also point out that the task force is made up of a number of individuals with different backgrounds. We've got researchers, we've got care providers, we have patients, family caregivers, and representatives of action and support groups. And none of the members of the task force work for the ministry. So we all are appointed by the minister, and the task force report is to the Minister of Health and Long-Term Care in Ontario. However, there is a secretariat that is provided by people who do work for the ministry. The Dean is here, one of those folks. And I can tell you that the task force simply wouldn't be able to do its work without the incredible support that is being provided by the secretariat. And a lot of the work of the task force is supported by contracts and outside inquiries that we need to have run. Of course, the task force itself has no funds, the ministry does. So we're really, really appreciative of the support provided by the task force. And our mandate, as you can see here, is to make recommendations to the Minister of Health. We're quite aware that, you know, the governments being what they are, that the minister we give our report to is not going to be the same minister who set up the task force back in 2016. But nonetheless, I think this is important work, and regardless of who that minister is, the minister will be receiving our report and taking it very seriously because, of course, it relates to the needs of a significant number of Ontario residents and what they are and are not getting right now in the way of health services. So I think regardless of who that minister is, our recommendations in that light should be seen as quite significant. So what we are supposed to do on the task force is recommend what's needed for a patient-centered approach, and I think patient-centered is really important. Improving supports for people living with the 3 conditions that I'll mention in a minute, and on the design of an education and a research agenda. So I think that's a pretty broad remit, and I think it's a really important one. I confess that I came in to the task force with a little bit of an academic background, thinking that the research needs were perhaps the most critical or the most key to develop, but I've changed my perspective after a few meetings with task force members, and I think really the care needs and what is needed in the way of change or improved care, access to services in the sooner rather than later is probably the most significant area of recommendation for the task force. And in that respect, I'm certainly very much looking forward to the input that folks here this afternoon can provide. Although we're all sworn to secrecy, you know, it's one of these government letters of appointment things about not talking about things until they're released. I can tell you right now that we are in the process of developing our final report, and that this is a really excellent time to provide input and have things considered by task force for inclusion in the final report. So conditions that are in our remit include environmental sensitivities, multiple chemical sensitivities, so abbreviated as ES, MCS, myalgic encephalomyelitis, chronic fatigue syndrome, which we abbreviate as NECFS, and fibromyalgia. And I've mentioned a little bit about the representatives. I guess I did omit that we have another ministry representative. It doesn't work for the Ministry of Health, but is actually the Ministry of Environment and Climate Change in Ontario, also as a representative on our task force. We have a 3-year mandate, so you can see 2016, 2019. I'm pretty sure when I looked at my appointment letter that 2019 meant January 2019. So we're now May 2018, and really the task force is coming into kind of the home stretch for writing up our final report. I am the chair. I think all members of the task force have equal kind of voice and vote, and as chair, personally, I see my job as trying to identify the largest basis of consensus from what are sometimes very heterogeneous opinions expressed by task force members, but I think my job as chair is to identify as much commonality so that we can have a report that has as much as possible in it in the way of recommendations that has the support of every task force member. So I think there's been some really good dialogue, some back and forth, and I think we are on the road to success with having a really good set of recommendations. So, you know, what I can report on is obviously the interim report and what has happened since that interim report. And I think the things to emphasize today is that based on the recommendations in the interim report, there was a statement acknowledging the serious impact these conditions have on the lives of patients and their caregivers, and certainly you know, open to additional comments that folks may want to make on that. The ministry was able to take some actions as a result of the interim report on the task force, and we're working towards a final set of recommendations to be provided to the minister before January 2019. Phase 1 of the task force, which as I mentioned was prior to my arriving on board, focused on developing shared understanding of the evidence and research. So what is it we know? Don't need to reinvent the wheel. What is the state of knowledge on these 3 conditions? What is the state of healthcare service, at least in Ontario, available to them? How much do healthcare providers know about these conditions and their diagnosis and treatment? And some of the findings in the interim report indicated that quite clearly, probably as no surprise to people here in the room, that there is a general lack of recognition and awareness of the seriousness and the severity of these conditions and the impact that they have not only in the lives of people with them, but also family members and others who are providing care for those individuals. A profound shortage of knowledgeable care providers. And I think we should not confuse lack of knowledgeable care providers with lack of interested care providers. And maybe I can elaborate a bit more on that later in the discussion. And again, I look forward to your thoughts and experiences there. And certainly a real shortage of clinical tools to support and guide care. And again, I think that's come up in some of the findings that have guided the task force after the release of the interim report. And really discouraging for patients with these conditions and their family members, shortage of services and supports for people living with these conditions. And I'm really struck by the recognition and the realization that this is not simply a matter of medical services. Okay, I mean, the comments that we hear is that really to provide adequate care and support for people requires a multidisciplinary team, and it is more than just medical care. And I think that's really important to reflect on. Again, any thoughts and experiences folks here have that they can share would be great too. And that certainly family caregivers are not well supported in taking on some of the responsibilities and care provisions, support provisions for people with these conditions. So phase 2, which is where we're now at, and you can see it says January 2019, which I'm sure has something to do with the date on my letter of appointment from the previous minister. So we're focused now on developing more detailed recommendations in really 3 areas, and I think comprehensive patient-centered system of care. I think system of care is really important to reflect on, because it's not just, can someone go in and get on a waiting list for a particular facility. I think it's much broader than that. And what is the complete set of resources or centers or venues where care can be provided. And I certainly listened with great interest to what they're doing in British Columbia this morning, and I'm sure there's some really positive things coming out of that, but I think it's very difficult to think of a single center as being adequate to provide what I suspect really needed to adequately provide care for most of these conditions. We need to look at some central expertise and resource perhaps, but I think for provinces the size we have in Canada, some sort of a distributed or regionalized model of care may be an important part of that. And again, please, I look forward to getting your thoughts and your input on that point. Research required to improve care. So, I mean, as I say, that was kind of my focus perhaps a little bit when I came in as chair, with my former dean pushing me to take this on and having kind of an academic or a bit of a research orientation. Research is really important, and there are different types of research that are perhaps done somewhat differently in the community and in laboratories and teaching hospital settings. So I think research is really very broad and spans everything from looking into mechanisms of disease and pathogenesis that can be done maybe in specialized research labs, but there's also research into what works and what doesn't work in providing treatment and care. And I think some of that work is really perhaps done better in clinics and in community settings, and learning more about what does make a difference and what doesn't. And I think diagnostic tests, laboratory tests, very, very important, but certainly part of my clinical training was you treat the patient, you don't treat the test. And I think we need to look at research both into better tests and how to come up with what are mechanisms of disease and pathophysiology, but we also need to look at what works, what doesn't work, and who does it work on, because not all treatments work on everyone. And I think we heard a bit this morning already about, not every patient would require, or not everyone requires sodium restriction, perhaps to the same extent. So I think trying to learn more about not just the similarities, but also some of the differences and how that relates to care is an important research question. But again, I look forward to your input. And education who needs the education? So we talk a lot about physicians, but I think it's really a broader set of healthcare providers in all likelihood. And I mean, I've done a bit of work in what works and what doesn't work in professional education and continuing professional education. And I think there's some of that research is very helpful in allowing us to answer questions about what are some of the really key gaps right now in provider knowledge about these conditions, diagnosis, treatment, and how to look after patients. And certainly public education as well, that there needs to be better public recognition, and of course, you might go far broader and say, well, you know, insurance carriers and disability organizations need to learn more about these conditions as well. So education, I think, again, can be pretty broadly scoped. So current status, the interim report was submitted to the then Minister of Health and Long-Term Care, July 2017, and it was called Time for Leadership, Recognizing and Improving Care. It was basically what the task force at that point in time had come up with in the way of current state of knowledge, awareness, and care regarding these conditions in Ontario, as well as suggested interim steps for the ministry to take. And we have a task force member here in the audience, Maureen McQuarrie, who can provide far more information on what went on before I arrived than I ever could. For me, as someone who's watched governments, you know, with some degree of intensity over time, the report appears to have been well received by the ministry, and they did make it public in September 2017. So I think that for me would be a positive, that the time lag between when the ministry received the report and when it was released was, in my experience, fairly short. Others may say, what, July to September? But if you know how government organizations work, there's a lot of internal process there. So I think that was a pretty timely release, and they did acknowledge with a statement in one of the ministry publications the serious impact these conditions have on patients and caregivers. So that was the supportive public statement in the health bulletin. They did set aside some money, up to $200,000 for the development of expert consensus on clinical case definitions for these three conditions. That work is underway right now, and I think folks here are aware that it's certainly not the first time that a group has tried to come up with clinical case definitions. But again, as we heard this morning, I think someone made a comment about up to 43 definitions. I think the desire was to have, you know, a recognized or a vetted or a recommended set of clinical case definitions for providing care in Ontario. And I think I would be very, very surprised if the expert group that is going to come up with these definitions for our task force departed significantly from what has been done before. So I don't think they're starting with a blank sheet of paper, but I think it was a need to get the best expert input right now for Ontario and what should constitute clinical case definitions. And then the other positive thing that was done after the interim report is the ministry did extend the funding for an enhanced skills program at Women's College Hospital and U of T. So that is a program being run through the Environmental Health Clinic at Women's College Hospital and Department of Family Medicine. So the interim recommendations in detail were change conversation, increase understanding, recognition, so the formal statement. The academic chairs, I think, is an interesting, important recommendation, but my understanding is that would probably be out of scope for the Ministry of Health, and that is not something that they are currently active in. Modernizing fee codes is something that is easier to say than to do, and to do something like that, and I think there's still, as I understand it, discussions underway. That is something that has to be negotiated between the ministry as the payer and the physician group, in the case of Ontario, the Ontario Medical Association, to achieve that kind of change. So that is something that would require some degree of agreement on that, but that is potentially doable. Develop a common understanding, so that's where we're headed with the clinical case definitions. I think the task force reached a pretty good understanding, but to see this kind of formalized and vetted by a group of recognized or nominated experts in this area, really, really helpful. Clinical practice guidelines, you know, I think there's a bit of debate as to what's a guideline, what's kind of a standard of care, what are best practices, what are tools. So there certainly is a recognition that in addition to the case definitions, you really have to tell or have to provide some resources to healthcare providers that, okay, so suppose you use the clinical case definition. You make a diagnosis, now what? So it's the now what, the tools for care to enable better care that we're really, I think, wanting to focus on. And that may be a clinical practice guideline, it may be tools, but the important thing is the goal is to improve the quality and the access to services for people with those conditions. So those of you who have a very narrow definition of clinical care guidelines, it may be a broader set of tools that we're really looking at, but it's an emphasis on what's practical, what will make a difference. Lay the groundwork for patient-centered care. So, this is where, again, we're really looking for input. There's been some really good discussion on models of care. I think it's reasonable to say that when we're looking at these conditions, not many folks around the table are talking about cure. We are talking very much about care, improving function, maintaining function, preventing people from getting worse, and providing the very most that can be done for people with these conditions. And when you think about a lot of other chronic conditions, diabetes, coronary disease, chronic obstructive pulmonary disease, these really aren't conditions where we talk about cure as much as care. We certainly do diagnose, we certainly do test, we certainly have therapies, but the emphasis is I think, far more on how do you maximize functionality and how do you maximize wellness for people that have some of these conditions. And I mean, if there is a cure, obviously we want to implement cures quickly. But for a lot of our chronic diseases, and I speak as a physician, I think we would be a little bit optimistic if we talked about coming up with cures. But there's a heck of a lot we can do to support and improve the lives of people with many chronic diseases. And I think there's a general feeling on the task force that not all that has been, could be, or should be done for folks with these three conditions is being done right now. So our focus is on what can we do to provide better care. And then making hospitals and long-term care homes safe for people with these conditions. So some of that relates to things like set-free policies, but also building design, and are there specific kinds of environments that are needed in parts of the healthcare system that patients with these conditions access. And then increase the number of knowledgeable providers. Again, the Enhanced Skills Program for third-year residents has received funding. I think that's a very important program and initiative. I get some of those folks coming, spending time with me in my work with Public Health Ontario and environmental health research in general. But I think if we look at increasing the number of knowledgeable providers, it's really difficult to view that as something that we can do with a few additional training programs. I think we have to look at what's the pool of current healthcare providers in Ontario or elsewhere, and how can we identify those providers that really are interested, do provide service, and want to provide better service for folks with these conditions, and how can we increase their knowledge level. And certainly one of the things that's been done is to do a survey of only physicians, and I think other healthcare providers are an important part of this picture as well, but take a look at what is known by physicians, what's the level of interest. And again, those results aren't yet public, but some really encouraging findings, I think, from an Ipsos survey of physicians in Ontario with respect to their interest in learning more, the fact that they are providing care to folks with these conditions and they want to do a better job. So I think that's where a focus on how can we build a better system of care that primary care physicians can plug into on a local or regional basis is maybe a really important consideration, as well as what can we give them in their offices and in their practices to provide better and more effective care. So current priorities, as I mentioned, we've got 3 working groups, that's research, care, and education. So all 3 of these working groups meet separately, and then we come together as an overall task force So kind of the detailed recommendations in the care, education, research areas are the substance of the working group meetings, and then the overall task force comes together, and the three working groups share their progress in their areas with a view to coming up with a really good integrated set of recommendations that covers off all three bases and that can be supported by all members of the task force. At least my goal would be to have a report that has support from all task force members. You know, I think having two reports, a majority report and a minority report, would not be very helpful, and I would consider myself as having failed if it gets to that point, but hopefully not. Ongoing inquiries, so, you know, I think there has been really good support for the task force by the Secretariat. They have engaged in a number of contracts with outside providers, you know, a survey that was conducted to find out level of knowledge and interest in learning more and what needed to be learned. We're doing a kind of Delphi process, which is a process where you poll experts and you try to achieve an expert consensus for the clinical case definitions. And there certainly is interest in moving beyond just the definition and how much can we recommend or how much can we identify in the way of tools that would be helpful as well. The task force has benefited, I think, by presentations from a number of very you know, knowledgeable and interested individuals. So, you know, Alison Vested, who was one of the speakers this morning, did come in and provide a presentation of the task force. Adriana Tetley, who's the CEO of the Association of Ontario Health Centres, came in and gave us you know, a report and update on the work of community health centres around the province and possible services and roles that they might be able to play that would be helpful. And there was a business case proposal for an Ontario Centre of Excellence in Environmental Health, and that proposal is very much under consideration by the Ministry and the task force, and we continue to use that as a reference. Certainly you'll find it on my credenza in my office. Commitment, as you say, we'll have our final report ready in time for the end of the mandate of our task force, which is January next year, and we will be making recommendations on improving support, education, and a research agenda for people living with these three conditions. Our emphasis is very much on, how much of an improvement can we make as soon as possible, because we've heard a very clear message on urgency from many task force members and the organizations they represent. And certainly, I am really delighted to have the experience, expertise, participation of folks who have lived with these conditions and people who have provided support for them, and organizations that have a critical interest in improving care for folks with these conditions on the task force. And although we can't have everyone on the task force, I think having meetings and discussions with groups like one this afternoon is also an incredibly valuable way of broadening the input to our task force. So there, I'll sit down, well maybe not sit down, but I'll shut up and now listen to you folks, and we look forward to your comments. And Dean's here.
Thank you. Rick Arsenault from the Complex Chronic Diseases Program in Vancouver. So can you hear me?
No.
Still louder. Okay, I'm a low talker. Perfect. Rick Arsenault from the Complex Chronic Diseases Program in Vancouver. I think the point that you made about educating physicians is probably the key from my perspective. When we set up the program, we ended up with a lot of disappointed patients because they wanted us to take care of them forever. And you can imagine if the Statistic Canada report that 1 in 20 Canadians has these conditions, plus if you look at these conditions as part of the spectrum of central sensitivity syndrome, it's estimated that 1 in 5 primary care physician visits is related to a central sensitivity syndrome. And when you ask clinicians, including my students who I see every day, how much training do you have about this in medical school, the answer is still 0. So we spend a lot of time teaching at both undergraduate, postgraduate, and the CME level. But I think, like you said, developing an interest in legitimizing the condition that think are two barriers to making change. So thank you for your work. In fact, we use your report a lot.
Great. Well, certainly we're very interested in what's being done in BC and hearing from others about what that does and maybe some of the gaps. And maybe we could talk at some point about what you do differently, either you do it over again or maybe you do exactly the same things. Yeah, I think the number of patients is something that we've really sort of grappled with ourselves, and we're aware of the CCHS, that's the Canadian Community Health Survey results. I think in Ontario we're even more fortunate than BC, having worked in both provinces, and having ISIS, the Institute for Clinical Evaluative Sciences, and we've gone to that resource, which contains all of the health outcome data, try to get a better handle on how many people may have these conditions. So, again, we've had some really interesting insights. Not as much as we'd like. I mean, the data will never answer all your questions, but there's certainly some really interesting care utilization patterns that we're aware of. And, what that indicates in the way of lack of service, I think, is really important, and how we can do better.
Other questions?
I'm concerned about the lack of attention paid to the biologically based symptoms of the illness, as well as comorbidities that evolve with the illness. In this country, I'm coming from Nova Scotia. I am originally from Ontario, but that is what I see in terms of the treatment, supposed treatment of patients. And that's what concerns me, and there's plenty of scientific evidence at this point which certainly underpins the molecular basis of the illness, and so that's my concern, and what do we do about it?
Okay, so if I'm not being made available, that would flow from some of that biologically, I think for the care, that's really what we're interested in.
So a prime example was this morning to talk about orthostatic intolerance and how that can be very easily tested for and then even treated with respect to blood volume, perhaps compression, stockings, these sorts of things. Oh, there we go. So these are the sorts of things which I think, and that's a fairly easy thing, I think, to assess and then treat, but I don't see that happening within the context of certainly the clinic I attend. And so what can we do to at least have these basic diagnostics available and treatment plans available? Because that will go an enormous way toward improving the quality of life and the ability of patients to then become contributing members of society again, and so on and so forth.
Yeah, no, I think that's an excellent point, and I mean, certainly some of the research that needs to be done is to look at, what kinds of therapies along the line you mentioned for OI can be made available, and there's a lot more that can be done, and to the extent that we have, whether it's clinical practice guidelines or tools, we want to make sure that those therapies or those treatments, that care is made available as soon as there's evidence of, plausible evidence of effectiveness. And again, another thing on the research side is I think we're really keen to see some evaluation of systems of care and make sure that we really are making a difference for patients. So, I mean, this is all, I think, excellent stuff, and to the extent we can get that into the recommendations, we'll certainly look at it.
My son was diagnosed he was only diagnosed about a year ago, thank you. And it took us 7 years and umpteen doctors. So I have a number of points I would like to share if you don't mind. I think what you're telling us is very hopeful. I think this is wonderful that all of these things are taking place, and I think this is a real opportunity to see a paradigm shift in the treatment. There's a few paradigm shifts in the treatment of patients by physicians, because we were not believed. I'm sure the story is the same. I was told it was my fault, they need to back away. he had depression at the same time, so it was written off as a psychological issue. Okay, there's a few things about it. So the second thing I want to say is when he went to the doctor, he had so many different symptoms, and we were stovepipes. So we saw lots of specialists, but I kept asking, can we have a project manager that understands the interconnection between all of those symptoms? That does not exist. The other thing that I think is important is that physicians are able to bill for appointments that are long enough to hear all the symptoms. And I think if they don't have time and they feel that, you have to get us in and get us out, that's a real difficulty for the patients and for the doctors. The system seems to be set up to kind of counter the positive diagnosis. The other thing is, I read that this is an epidemic, and forgive me, I'm not as well versed as so many of the patients and so many of the caregivers in this room. I read that it's an epidemic, and I wonder, are there business processes that are in place that can be kicked off? Because I appreciate so much what you are doing, but as I listen, it's a necessary and slow process. Government it's a slow process. But are there not business processes that can be kicked off when something is called an epidemic? Because I think about, and forgive me, there are a lot of physicians in the room, and I don't know the difference between the terms, but AIDS and SARS and all these things that came to be that impacted people, things were done immediately. And as I think this lovely woman here, her daughter is terribly sick. And I think as I listen, she laughed, as I listen very hopefully at your message, it's slow, and people need help. And are there not processes that can be kicked off that allow for the education of these physicians so that they start to understand? I have to go to my son's GP and every time bring her another piece of paper, and hopefully she's not insulted that I think I know more than she. But I know I feel the roll of her eyes, but she's lovely. But anyway. And the other point I have is, how do we know what we're dealing with when my experience is very few people are diagnosing this? So how do we even know? Like this, if we see it as an epidemic and we still don't know the full impact in our country, how can we do the right thing? So I'm sorry there's so many points, but I just can't help but think when there are people who are suffering like they are, that there isn't a process that can be kicked off in parallel with the good work that you're doing.
Yeah, great points. Thank you very much for that. And I guess I don't know what to say, but that I think we all recognize it's a very large group of people who are not having their needs met. Whether that is technically an epidemic or not, don't know. But certainly there's a large unmet need, and it's for a lot of people. So it's an important problem, I think, no matter how we slice it. Kicking off a process, declaring emergencies, which happens on occasion, so something like the opioid epidemic in British Columbia, I think that did result in an emergency. Realistically, what that triggered, as far as I understand, was better information gathering. So, I mean, there really isn't anything I'm aware of in the health field that allows us to flip a switch and all of a sudden something just moves into into place. What you also mentioned, I think, is really, really important. AIDS and SARS. So if you look at those two conditions, what got kicked off, at least in my assessment, was there was a huge stream of research projects that were kicked off by, sort of the onslaught of SARS and AIDS. And, I mentioned my biases when I came in that I thought research was really, really important. I do think it's still important. I think it's a really critical part of what the task force will recommend. And I think that a lot of what we lack is probably really good, solid research into these conditions and, their natural progression, subsets, biological markers, more effective therapy. So I think there's really a significant unmet research need here. And in research, it's really, in Canada, CIHR. And I mean, Maureen, you pointed out that there was a call that CIHR at long last had for researchers to put in proposals that would really tie into, I think it was really an NIH, National Institute of Health in the States, funding. So I think the research pot is really important to fill, and those agencies and the publicly accountable officials who oversee those agencies, if they heard a message, more research is needed, I think that would be really helpful, because I think if research dollars are available, anyone at an academic institution, our lifeblood is research dollars. If those dollars aren't available to go after, you won't be harnessing the interests and kind of the capacity of those institutions that we already have in place. You make that research funding available, you put out calls and say, there's X $100,000, X $1 million for research into this area. Anyone who's anyone in academic medical institutions isn't going to want to go after that. So I think a root cause, there's a really important thing to be perhaps done there, and I think the folks in this room, individually and through your organizations, can really play a role in that.
Right. Just back to my point about the lack of diagnosis and the lack of knowing about the numbers. I guess my point about that is, if we truly knew, as part of your report, are you looking at any kind of an activity to understand the numbers? Because I think the numbers speak, right? The numbers speak about funding. The numbers will speak about how big an epidemic this is. So to me, it's that whole idea of kicking off something that says, okay, these are the numbers, we should be a little bit concerned. And the numbers, not only just the numbers today, but the numbers that are growing. And then somehow kick off some expedited funding for research, because people are doing God's work in trying to get money for research, and we're all donating our money for research. And it's just, I think we don't even, it's like the unknown that we don't even know when we're dealing with. That number is unknown, and when doctors don't diagnose, how I'm frustrated in that it's, nobody really knows what it is, and I think there would be more concern if the true numbers started.
Yeah, no, and I mean, certainly researching and getting a better handle on what the numbers are using, different criteria or definitions. We've got the CCHS stuff. There's some really important big numbers there. We've gone, at least in Ontario, to the Institute for Clinical Evaluative Sciences and through healthcare utilization, trying to get a bit of handle there. The other thing, too, that sometimes does influence policymakers is not just the people numbers, it's the dollar numbers, and the extent to which, perhaps they're inappropriate investigations being done that don't just cost those organizations money, but I think in many cases would actually place patients at risk without much benefit likely to accrue from some of the investigations that may be done. So really important stuff there. And
we've got a couple of other questions in the audience. I think the important point is you're leading an Ontario task force, and I'm an Ontarian, that's wonderful. But this is a national problem. If there's any way in the report you can refer to the scope, but then bring it back to Ontario, which you have to, because it's the ministry, but this is a national problem. So I just wanted to make your point. So I've got 1, 2, 3, the next.
So I mean, thank you, and you're right, but you're wrong.
Okay.
Because I don't think it is national, I think it's international. It really goes far beyond just Canada. So we all get the point that it's big.
Thank you.
Yeah.
Can you hear me?
Okay, great. Deb Reason from Manitoba Support Group. Okay, yes, I believe too that we need a national registry. We need a Made in Canada solution. We are unique in many respects. But this is the first opportunity. We do thank you. My question is, I listened to your webinar and I wanted to know, you mentioned that we could use your document. It would be great not to reinvent the wheel. So when I meet with the Manitoba health ministers, can we utilize your document? And you said yes, but your final recommendations are next January, and you're within the middle of your amendment date, but also we hope that it doesn't sit on the shelf.
Right, so any document that's publicly released can be used by the public for, whatever purposes you see fit. Our final report is due January 2019. We expect that we should have the report ready for submission, hopefully before that. And once we give our report to the minister, we lose all control. Okay, because once the report goes to the minister, it is up to the minister to decide what she or he wants to do with that report. So until that report gets released, it cannot be shared or put into the public domain. So that report, once it's sent to the minister, then the decision maker is the minister, and of course they will decide as they see fit. Publicly elected officials tend to be sensitive to the public, so we expect that it will be released at some point, but apart from that, we don't know.
Hello, my name is Denise King. My first question actually was for, I'm sorry, I missed the beginning of the session, Margaret, so you're Margaret Soden. My question was, you had asked a number of us to respond to the task force's year one report. Correct. And so I guess my first question was going to be whether you found any commonalities or things that kept coming up in the responses that you got. Yes. So I would like to pose that question to you. I have some comments. Would you like to mention them first or turn it over to you?
So we're really thrilled that we're handing over to Dr. Copes and Dean of the ministry today the incredible input of 24 people across Canada. There are some themes in there, but to do justice, and many of the inputs came in last minute. I mean, we're all busy, so whatever. No, we haven't had the proper time to do that analysis, but I mentioned to Dr. Copes earlier today that that is a piece I would like our group to do after the fact and to correlate it to the report. But in the meantime, you've got it, and I know you'll work with it in the meantime. Okay, so no, I don't have the absolute themes.
Okay, thank you. I was just wondering about that response, so thank you. Yeah. I understand that. I just had a couple of comments to make if we're just asking questions and making comments. I am a patient, 14 years. And my first comment rather would be, you spoke in the task force report about very much wanting not to reinvent the wheel. And so, actually, let me back up a second. I would actually say, if I had only one thing that I could say, it would be your recommendation 4.1, which is, if nothing else, bolster in Ontario the environmental health clinic. Because that is our center of excellence. We already have that, but they are funded for a total of 0.8 FTEs, full-time equivalents. And so, I mean, that's just, it just doesn't make sense. And as we saw earlier, Rick, in your group's presentation for the Vancouver, or the BC clinic, my question about, you were talking a lot about re-referrals. Well, of course we're going to have re-referrals because patients need to keep going back. Their GPs do not understand right now. But the most important thing, if nothing else, would be to fund that clinic and fund it up. I mean, we don't want to reinvent the wheel. We've already got them there. We've got our ME specialists. They actually do have a medical specialty under the auspices of Women's College Hospital. And I just think that should be bolstered up. I think it should be 5 or 7 FTEs or however it would work. And that patient, GPs in my experience, they desperately want to refer patients out. If there isn't the stigma, if they don't have negative thoughts about patients with ME, and they just say, well, it doesn't exist, or I don't want to treat you. If they're really interested, they really, really want to help their patients. They want somewhere to refer them to. And so I think that we really need to bolster that. If there was nothing else, I would say that. Going back to what I started with, not reinventing the wheel, as I said, use and expand the environmental health clinic. In terms of GPs, I think the biggest bang for your buck is disseminate the IACF-SME 2014 primer. That I have found doctors to be most receptive to. It's written in a way that GPs, the way they look for information, failing that, or in addition to that, of course, the 2015 IOM report, which has credibility. They both have credibility. But I mean, if nothing else, get out to every, I would say, please, get out to, if you can, get out to every GP in the province that IACFS ME primer. Because then, at least you're not going to have doctors who are embarrassed when someone comes in and says, I've got ME, and they don't know what to do with you. Well, at least they would have something. They would have something to start with, even if they're not fully educated, don't have CMEs in it. And I would really say that, yeah, in general, though, this disease is not ready for GPs. We are nowhere near ready for GPs apart from what's in the IACFS ME primer. And that's why I really think we need ME specialists. I mean, in other fields, we've had 30 years with HIV, MS, that used to be called hysterical paralysis, right? Until, as Nancy Clemens says in the Unrest documentary, until they saw the lesions on a CAT scan, until I think she says the day the CAT scan was invented. So we're 30 years behind with ME. And I just don't think it's ready for prime time, so to speak, for GPs. I think that's why we really need to focus on the EHC specialists. Thank you. Thank you.
Thanks. Well, I know Fadine's been busy right and late here, so I suspect he's captured all, or at least the vast majority of that. And I guess, the challenge is a bit, aligning the numbers. So, if you take the number of folks and the availability of care and what can be provided in the short term, you're sort of looking at one clinic serve a province? And I think looking at a distributed model of care, different levels of care, primary, secondary, tertiary, is kind of where folks are thinking around the system of care. Because we know the demand and the need is huge, and it would be very difficult to think of how, in a relatively short space of time, because again, we're told care is needed soon, not later, how you could train up large numbers of new practitioners. So we're looking at how do we most effectively move ahead with the most improvement in access to care that we can get, given that we've got a healthcare system that has certain providers and structures now. And how can we find a way to deliver the most effective care to the folks who aren't currently having access? And everyone recognizes the Environmental Health Clinic at Women's College and the work they've done. But if you double or triple the number of FTEs and you have tens of thousands of people, it's still very difficult to look at a model of care that wouldn't rely on a broader set of resources. So how can some of those resources that you point out be made more available to primary care physicians, and maybe regional or community clinics is also very much part of the sort of thinking. Yeah.
I just wanted to say that, just very quickly, I'm looking at other models, like other specialty clinics that I have attended because of comorbidities. And, I don't find it unusual at all to be sitting, in a hospital waiting to meet with specialists and be surrounded by patients who come from all over the province. They will travel by train or plane or whatever to get to the specialty clinic, because that is where the expertise is. And that's what I really emphasize. I can't emphasize enough how important I think that is. And not the distributed model. I just don't think we're there. Once we have the ME field is 30 years ahead of where MS has come and HIV has come and all of those, okay then. But at this moment, no.
No, those are really good points. And one of the other inputs we've had is I can't travel for my care. So we're looking at a fairly large and diverse group of patients, and how in an area that is as large as Ontario or many other provinces, how can you best go about identifying what that need is and constructing a model or system of care that will be as effective as possible in meeting the needs of as many people as you can. And certainly there are going to be specialty clinics, there will be people who travel to specialized care, absolutely, but again, we've got to look at folks who are less able to travel. What is that need for service and care closer to home in the communities, and how do you come up with something that maybe best address as many needs as we can identify?
Can I interrupt just as the facilitator to keep it all going? I need to pull a couple of things. We've got a late 1, 2, 3 more people that want to ask a question. And then are you a question as well? So 4. We've got about 6 minutes. Could you ask that question?
Absolutely.
Please, you're 1 minute. Okay, you're on.
I'm Teresa Clark. I'm one of the GPs at the Complex Chronic Disease Program in Vancouver with a special interest in acupuncture. I just want to make a brief comment. Clinicians who are interested in this field are a very small proportion of the large medical field. So there are very few of us who are clinical special interest in the front line, seeing hundreds of patients a year. Like me, I may not be necessarily associated with any of the researchers in the academic centers who would be applying for grants for the research. So the comment I want to make is that clinicians are seeing some patients somehow find ways that improve their success rate in rehabilitation and improving their quality of life and going into remission. And of course, my ears perk up whenever I hear patients who tell me about things that they're doing. I think that clinicians who have this experience should be talking to the researchers in the academic medical centers who are not seeing the clinical numbers that we are seeing, and they are not seeing the rare situations where patients are doing really well, and we need to learn from the successes. The more we focus on the pathology, we may know more and more and more about the disease, but we are now not focusing on the ones who have somehow made it to wellness. And we need to study those patients. We need to get these ideas that we as clinicians have into the research field where they are in the academic medical centers. And this is part of the urgency that I'm hearing from patients and patient representatives, that they want to see clinical improvements coming forth up the pipeline quite quickly, a couple of years. So the only way is to get the clinicians connected to the researchers to give them ideas as to what we see could be possible lines of research that would be helpful for patients.
Yeah, no, fantastic.